can't listen to you. So.
Thank you very much. So I think we are, 15 minutes late? So we'll try to ask people to stay on time, and we'll start right away. We have 4 talks. The first one is by Dr. Wilkins, who will give a talk on the future of HIV infection. Big title.
It really is not to repeat things that have been said before by some really good speakers, excellent speakers. And so this is what I'm going to do. I will skip through a few slides because you've seen them this morning or you've seen them yesterday. So forgive me for that, but it will speed up the talk. So I want to talk about drugs, vaccines, and cure eradication. And listening to what has been said, I think cure eradication has been pretty well gone into. I'm going to talk a little bit about vaccines because we haven't heard too much about that, and also the new drugs that are coming along, and not spend too much time on where we are at the moment with drugs. So what is the problem? I mean, we need drugs, if everything goes according to plan, we need drugs for 50, 60 years. And if you think of those children born today, you know, if they're well cared for and they take their treatment, you know, it may be 70, 80 years we've got to treat them for. So we've got to have the perfect drugs. And so we need drugs that have no kidney and no heart and no liver toxicity. And that may be impossible because all drugs, you know, we all say to patients, whatever the disease we're treating, you may get a side effect from your drug. But really the aim is to have things that are drugs that are absolutely free of long-term toxicity. And as Jyoti has said, we want drugs that are completely safe in pregnancy. The problem with that, of course, things have to get onto the national registry, so they've been used 1,000 or 2,000 or 10,000 times, and only then do you have the confidence that you can advise the mum that that drug is safe. And the trouble with dolutegravir at the moment is just not being used enough times. But there is no reason to anticipate it's not going to be completely safe. The trouble with infants and kids is that the drugs are always tried out in adults first, then it's adolescents, and then we get formulations in children, and then we think about infants. And really what we want is for drug companies to do everything at the same time, like they're doing now with co-infected hepatitis C HIV patients, that is done at the same time, the same trials. And of course, we've got good adherence now. We've got 5 single-tablet regimens, soon to be increased to 6. But what about the chaotic? And I'm just going to mention long-acting drugs. Is that an answer for the chaotic people, the people in prisons, the people who don't come to clinic, you know, that we just give them an injection every month or every 2 months? And possibly more important than anything else, certainly for us old people in the West, is with the polypharmacy of age, we want drugs that do not have any drug interactions. And the boosted protease inhibitors, I feel, are going to be with us for a long, long time because they have a lot of advantages, but my golly, do they have problems when it comes to interactions? Whereas the integrases don't have that, and of course dolutegravir is now classed as a drug which has a lot of similarities to a protease inhibitor with regards to a high barrier of resistance. And that those integrase inhibitors don't suffer from the same drug-drug interactions. And of course, we have to remember there will always be resistance. We had a great plenary session on resistance yesterday, and it talked very much, the speakers there talked very much about how much a problem resistance is, especially in the middle-income and low-income countries. So, the charge is now that we have to keep 90% of our patients undetectable then for hopefully 50 years, which is a real task when it comes to an antiviral combination. So this is what is happening in the West. We are shifting wholesale to integrase therapy. We in the UK have to follow certain guidelines, and the guidelines are set really by the government partly to use the cheapest alternative that we can that gives the same amount of virological suppression. So efavirenz and Kyvexa, for those that have a low viral load, below 100,000, is the #1 option. And we looked at 100 patients, and we put 3 patients on that combination. The majority went on to dolutegravir and Kyvexa, which was the next one along the line. So we are finding reasons not to use efavirenz. Although, just like Jyoti has said, and a lot of people have said, I have most experience with a tripler than other combinations, and then you feel comfortable with it because of your clinical experience. But the great move of the bulk of physicians now is to move to integrase therapy because there are fewer side effects. And if you look at the persistence, being on a combination, being on that third drug, it seems to be most effective with an integrase drug. And the top line here, blue, is the number of patients that have virological suppression on their combination. And this is from Canada, this data. And you can see that the blue integrase at the top, and not the blue nucleoside at the bottom, is the third drug where you see the best virological suppression, the best persistence on therapy. So we've talked a lot about TAF. Just to summarize, same efficacy as tenofovir, less bone and renal effects. I think we all understand that now, but I think the most important thing is we can use this with GFRs down to 30, and that's the key thing. Whereas you can't do that with Carvexa, you can with abacavir, but you have to split it up. And you can't, of course, use it with tenofovir. Doravirine is another version of efavirenz. It just has less CNS side effects, but again, single tablet, fixed dose combination. And there is a new integrase inhibitor on the block, which is GS9883, where there's little information, but that's co-formulated with TAF-FTC, or Descovy. So you've seen this. TAF is as good as tenofovir. I'm going to skip through these slides. You've seen this. Less impact on the kidneys, and that's the important thing. You don't see the same tubular damage, and you don't see the same bone demineralization as you do with tenofovir. This is the key thing. If you put somebody who's got a GFR of 30 on it, you don't see it going any lower. And in fact, what you do see is improvement in the tubular damage, which is important. But it's not as if it suddenly improves. It's just a safe drug to use, just like abacavir is safe. Doravirine versus efavirenz, and you can see, just looking at the right histogram there, that there is no difference in an ITT analysis, virological load less than 40. And the reason that is, again in the red box, is you can see there's less CNS side effects. So this is no different to, say, rilpivirine versus efavirenz, where you see many less side effects. Resistance. Now, it's always going to be with us. We had those patients who started therapy in the middle 1990s, maybe before then, where they had pre-ART nucleoside therapy. They have taken their tablets religiously. They've taken their first-generation PIs, their first-generation non-nucleosides, and they have this incredible profile on a resistance test. But since about 2006-07, when we've had darunavir, ritonavir, etravirin, moraviruk, raltegravir, if they take their tablets, then we've got an undetectable virus, even today. But of course, a lot don't take their treatment. And so you have very resistant virus. And that is in the West. And in the low-income countries, then you've got people who don't have access to a lot of these drugs, who are not having viral loads and viral resistance tests done. And so when it comes to it, and you've seen this slide, and you do resistance, and this is in the second-line study, it shows that there is an enormous amount of resistance that exists in patients where viral load is not a routine in monitoring patients when they come to failing. So what about antiretrovirals that have activity against resistant virus? I can see I'm down to 6 minutes now. Dolutegravir has a lot of activity, and there are now proof-of-principle studies that you can use dolutegravir monotherapy and dolutegravir and 3TC. I think we have to wait for full phase 3 studies to go through with this. I'm very skeptical about using an integrase inhibitor monotherapy. I think it's too dangerous. And dolutegravir is just too precious a drug at this moment to start playing about with it. GS9883 we know very little about, but that's going through phase 3 studies. It's a Gilead integrase inhibitor that does not need boosting. So it's very similar to dolutegravir, and it's co-formulated with TAF and FTC, so a single tablet. So very much in competition with Triameg. Then nucleosides, nobody ever produces new nucleosides. We have TAF, I'm not going to talk about that. And we have this EFDA, which is a nucleoside that has activity against resistant virus. I'm a great believer that dual therapy without nucleosides is not something that we're going to be moving forward with for the moment, certainly not in naive patients. None of the nucleoside-sparing options have worked as well, whether it's a PI, an integrase, a PI, an R5 inhibitor. They never work as well as using triple therapy. Maturation inhibitors, attachment inhibitors, and neutralizing monoclonal antibodies I'm going to touch on in the last 5 minutes. So the maturation inhibitor, this impairs the last step in the maturation of the virus before it's excluded from the cell. And BMS have been working on this, and they've been gradually improving it. It's still not active against every virus, but the drug that they have now in top dose has an activity in monotherapy of about 1.5 viral load. So I think that's an area for people who've exhausted other options where they possibly have a new drug that will be active. There's an attachment inhibitor as well, BMS 626529. It's just a number. But that works in 2 ways. It causes a conformational change. I can't point at the slide from here. In the left-hand picture, where there's a little cross, red cross, it causes a conformational change there, and it inhibits the binding of the virus to the CD4 cell site. And that, again, has an activity, and these are very early phase 1/2A studies, of up to about -1.5 in the higher doses. So, it's a watch that space. What about those really difficult to get to patients, the prisoners, those patients who don't come to clinic, the injection drug users, and of course those patients who are all over the place traveling, and the patients have preferences for not taking therapy every day, and yet taking therapy once a month would be something that would be attractive to them. And of course, we all have heard of the LATE studies, LATE-2, and this is nanosuspensions of cabotegravir, the new integrase inhibitor from ViiV, together with rilpivirine, which can be made long-acting and can be given, have been tried out in monthly and 2-monthly injections, and that is in the LATE study, and that was compared to daily oral therapy. And you can see in the top 2 bars, this is simplification when patients had an undetectable viral load on cabotegravir and Kyvexa. They then switched to one of these 3 arms, either monthly 400 milligrams cabotegravir and 600 milligrams rilpivirine, or 2 monthly with a slightly increased dose of both drugs, and a 3rd arm, control arm. And that basically showed excellent results. There were a couple of failures which were in the 8-week arm, and when they looked at the levels, they weren't as good. So at the moment, 4 weekly has worked. It's quite a big injection, and so I think there are still improvements to be made there. But for patient acceptability, it certainly was an acceptable, different strategy of delivering drugs. And another one is a nucleoside RTI, a nucleoside reverse transcriptase translocation inhibitor. And again, that is being tried out in a weekly dosing as a possible option to add to the other 2 drugs and to give us more permutations when it comes to long-acting treatments. Neutralizing antibodies, still some way to go. They're being investigated, but I think that is some way down the track. And I don't know whether we'll ever come to them, actually. Long-acting preparations, well, of course, they're the implantable combination antiretrovirals, not the injections, with, just like contraceptives, maybe working for 6 months. Of course, the concerns there are, you give something like rilpivirine, and you may get resistance developing, and you can take them out, but you're going to have drug around for a long time, and you're going to generate more resistance mutations if they weren't there to begin with. And then much more fancy, looking at vectors to deliver, in vivo genes and other ways of attacking the virus, but that's in the future. What about vaccines? They're tried, tested, and found failing, and plans afoot. I just want to say the utopia about drugs. What we have at the moment are the must-haves. Anyone coming up with a new drug must have conveniency, durable viral load suppression, excellent tolerability. I've got 14 seconds left. Helpful, you can see what I'm saying for the future is every one of these must be present when we come to drug therapy. So I'll be brief. Vaccines are just one element, and the least important element when it comes to all the others, from barrier protection to PrEP to TASP, in preventing infection occurring. Is a vaccine going to be necessary? Probably it is, in conjunction with the other methods I've just mentioned. Alvac was the original one that was presented in the NEGM in 2009. This was a sort of random generated one. It wasn't a designer type vaccine. And that showed, when you looked laboratory post hoc, that the non-neutralizing antibodies were mediated, and IgG antibodies against the V1, V2 region were associated with the reduced infection. And it reduced it by about 16 to 20%. There is now a large-scale HIV vaccine trial launching in South Africa, which is looking at a sort of upgraded version of this vaccine, increasing the numbers of boosters, using modified vectors and a different adjuvant. And I'm not going to go into that in detail. And of course, there are proof of principle vaccine studies looking at broad antibody-mediated prevention, AMP, and that has been touched on already, looking at IV infusions. Obviously, that's not the way forward on a large-scale study, but just looking at the proof of principle that they will work. Cure eradication, since I've just gone over my time, I'll just mention that this is something, of course, the only person who has been cured, and that was through bone marrow, is Timothy, the chap on the left there. And there have been further stem cell transplant trials that have failed to reproduce this. There's all this information about Mississippi babies, kids that have been treated very early on, and eventually the virus does come back after 2 to 3 years. And he is the only person. People have talked about treatment cure, functional cure, and viral eradication cure. I suppose I'm going to finish. I won't go through any of this. Would there be protection against reinfection? I think the answer is there will not. And okay, everybody talks about cure, but if you can imagine a world where we have a cure like hepatitis C, what is happening? People are getting reinfected. And I worry that that focus is going to move from treating as many people as we can as soon as they're infected, so test and treat policies and maintaining that viral load undetectable when there will be no transmission, to a situation where people come, they get treated, they get cured, and then they get reinfected. And between being reinfected and being diagnosed, they're going to infect a lot of other people. So I think treatment as prevention is the way forward, and not to focus on cure. And I'll finish there.